All right, Chapter 9, Respiration and Artificial Ventilation. This is the second half of Section 2 that has to do with maintaining airways and breathing. This chapter, very important chapter as well. Not only do we have to have the A, but we have to have the B as well. And so breathing is one of the biggest things that we deal with in EMS. The number one call for EMS is difficulty breathing. It's the most common call that EMS goes on. So this one is obviously very pertinent. So we have a large number of objectives for this chapter. If you haven't read the chapter, I hope that you will take the time to do that after you watch the lecture and make appropriate notes as necessary. Obviously, with all of these objectives, there's going to be some significant study time required. You're going to need to review these in depth and make sure that you are very, very well aware of how these play into the grand scheme of things. If this chapter is difficult for you and you're not completely on top of what this chapter outlines, you run a very high risk of the patient having a very adverse reaction to what you do. You could potentially have a patient who will die because you didn't do the correct procedure. It's a little brash, but it's very true. It's very, very important that we have a firm grasp on artificial ventilation and airway management. A couple of multimedia videos, and like I mentioned in Chapter 8, there are a large number of procedural videos in this week's chapter, and this week's materials on the web, as well as there's the King LT video or lecture that will help you get a better grasp on that device itself. Core concepts that we're going to touch on: physiology, pathophysiology of the respiratory system, how to recognize adequate versus inadequate breathing, principles and techniques for positive pressure ventilation, as well as administration of oxygen. So we start with physiology and pathophys. So kind of a brief reminder. We kind of talked about the anatomy itself when we were in Chapter 8, so we're going to spend a little bit more time on the physiology here in Chapter 9, being that this deals more with the process. So ventilation is the process of moving air in and out of the chest. Kind of a little pet peeve of mine, how in EMS actually it's all of healthcare really. We've termed this, when we check vital signs, we check for respirations. Well, respirations is not really what we're seeing. We're seeing ventilations. Respiration is gas exchange. Ventilation is the air moving in and out of the chest. So ventilation is this process. It is a two-part process. It is inhalation and it is exhalation. Inhalation being an active process requiring us to work and use energy, and expiration is a passive process, just is the natural relaxation. In order for ventilation to work spontaneously, we have to have working chest wall and working associated muscles. We have the lung tissue itself, obviously, the parenchyma, the alveoli, the bronchi, the trachea, so on and so forth. Provided that that airway is open and we can move air in and out of the alveoli, the process of ventilating then falls on the chest wall and the diaphragm. There has to be an interface between the lung and the chest wall. So that interface is the pleura. So if we look over on the right upper corner of the picture there, we see parietal and visceral pleura. Basically, it's one lining that is interconnected, but it connects around the edges, and there is space between the two layers. So there's the visceral pleura, which is around the outside of the lung, and there's the parietal pleura, which is on the inside of the chest wall, and there's a very fine amount of a minuscule amount of fluid in between there. I like to think of this as when you have, say, a glass bowl with something like Jell-O in the refrigerator, you get that little bit of condensation that makes that saran wrap on the top of that glass bowl stick very nicely. And that's how I like to think of how the pleura interact with each other. There's just that very fine amount of fluid in there that helps them kind of work together and stick together. Now, when the chest wall moves out, then the parietal pleura moves with it, the visceral pleura moves with it, creates a negative pressure within the lung, and air is drawn in. Then when the diaphragm moves back up and the chest wall moves back in, it creates a positive pressure, too much pressure, and it pushes the air right back out. Between the ribs, as we see here, and you can see they've cross-sectioned the ribs, you have muscles called the intercostal muscles, which kind of spread out and shrink in. The diaphragm is a dome-shaped muscle. I like to think of it kind of like a plunger. You push it down. Generally, if you push it down and it's not suctioned to anything, it'll pop right back up on its own. So it works kind of the same method as well. You have an area in between the lungs called the mediastinum. The mediastinum is the home to the heart and the greater vessels. And when we say greater vessels, we mean the super big, mega important ones like the aorta, the vena cava, both of them, superior and inferior, the pulmonary arteries, pulmonary veins. There are some other smaller structures that you may find in the mediastinum, but essentially that's the major things. So like I said, inhalation is an active process. That negative pressure pulls air into the lungs, and it fills those lungs, fills the alveoli. This process involves the diaphragm contracting or pulling downward or flattening out, and the chest wall expanding upward and outward. That creates a vacuum in there, and it sucks air in. So note that this is referred to as a negative pressure system. It's negative pressure ventilation. When we have to ventilate a patient, we have to use the opposite process, and it's actually a positive pressure ventilation that we use. So it's not as good, but it works. So here's kind of a little engineer diagram of how this whole thing works. So provided you have an open glottis there and an air source outside of it, the diaphragm pulls down, kind of like the plunger there. Think of this as kind of a syringe. The plunger pulls down, air sucks in. Exhalation is a passive process. The muscles relax, the size of the chest decreases, the diaphragm pops back up, the chest wall moves back in, and then the positive pressure is created in there. It's higher than atmospheric pressure, so the air then moves outward. And then here's their demonstration of that as well. Pushing the plunger back up, pushes the air out the open glottis. So we're going to get into some respiratory terminology. And this respiratory terminology can be fairly confusing, so make all kinds of notes on this as need be. So some of these terms that we're going to use, such as tidal volume. Tidal volume is the amount of air moved in one breath. This is usually somewhere around 5 to 700 milliliters or 5 to 700 cc's of air. So it's about a pop can and a half, if you want to think of it in that perspective. It's a normal tidal volume that we would see in a normal breath. That's not a take a deep breath. That's not just kind of barely whimpering along there. That's just the average breath. We have some dead space air, and this is air moved in on ventilation that doesn't make it to the alveoli. So remember, when you take a breath in, all the air didn't go to your alveoli. Some of it was in the bronchi, the bronchioles, the trachea, the mouth, the nose, the pharynx, so on and so forth. And that air is referred to as dead space air. That dead space air is there, but it is not able to be functional, because those parts of the body, trachea, bronchioles, and so on and so forth, don't do the gas exchange that the lung alveoli do. It has to be done in the alveoli. So the alveolar ventilation then would be the air actually reaching the alveoli. So if we add alveolar ventilation and dead space air, that will equal our tidal volume. The air that can do something plus the air that can't do anything is our tidal volume. Ventilation the term ventilation means both inhaling and exhaling. The term diffusion. Diffusion is a process of moving a substance from an area of higher concentration to an area of lower concentration. And I like to think about diffusion basically as somebody had Taco Bell before they came to class, and they sit in the corner of the room. Eventually the entire room will probably get to reap the, well, maybe not so much rewards of that person having had Taco Bell at one point. But as that person has, let's say, gas and releases that gas, has some flatulence, it diffuses throughout the room, so everybody can enjoy his Taco Bell. Or I guess if you wanted to think of it in maybe less gross terms, if you would drop food coloring or Mios into a glass of water, it may be a very sharp or very dark, rich color when it drops very first into the top of the glass, but it then diffuses out and becomes less concentrated. We have external and internal respiration. These two terms have to do with the area in which the gas exchange was occurring. So external respiration is that is exposed to the outside world. The only part of the respiratory cycle that is exposed to the outside world is that in the alveoli, because that came from outside air. So external respiration occurs in the alveoli, where the oxygen gets out of the alveoli and into the blood, carbon dioxide gets out of the blood and into the alveoli. We also have internal respiration. This is on the other end of things. So in the lungs, we had the external respiration. Then the blood went pumped back to the heart, and then it got pumped out to wherever it was going to go. Let's say your big toe, and your big toe cells needed some oxygen. That's where the internal respiration will occur, where the oxygen will get off of the blood, get out of the blood in your big toe, and the carbon dioxide will get out of the cells and into the blood in the big toe. So we have internal and external respiration, and it's in a constant cycle. So here we show in the cells, and they're showing, this example is showing the internal respiration process. So this is oxygen from the blood being diffused into the cell, and carbon dioxide is diffused from the cell into the blood. So this process works by diffusion. So let's say there's 21 parts of oxygen in the blood, but only 10 parts of oxygen in the cell. And there's 5 parts of carbon dioxide in the cell and 0 parts of carbon dioxide in the blood. Well, the body wants that to be equal, so it will move some over so it can be all even keel. So that's how that whole process works. It's the diffusion. And it's through very, very thin cell walls, cell membranes actually. Very, very thin membranes on the vessels, very, very thin membranes in the cells that allow this to occur. So categories of respiratory system failure. We have mechanics of breathing disrupted, we have gas exchange disrupted, and we have circulation problems. If one of these three things occurs, the others cannot function at capacity. They don't function well. So the mechanics usually have to do with muscles and bones and pleura and lung tissue and so on and so forth. Gas exchange problem would have to do with the cell membranes, the thickness of the vessel walls, the alveolar walls, and then any space that there could be in between them. Or it may also have to do with the environment. So if you walked into an environment that had zero oxygen in it, that would be a gas exchange problem because we would not have what we needed. And then there are also the circulation problems. We've talked about in the past hypoperfusion, which is shock. And hypoperfusion does not allow the appropriate good stuff to be transported out and the bad stuff to be taken out. So with the circulation problem, even though we have A and B, that just goes to show us that you still have to have C. They all have to be there to work together. So before we move on to respiration itself, there are a few more items in the text I would like to kind of touch on a little bit before we move forward. On page 199 and 198, there's a few things that I think are kind of key concepts. Number one, on 198, basically in the second paragraph under pathophysiology there in the mechanics of breathing, it refers to the tidal volume, which is typically about 5 to 7 milliliters per kilogram of body weight. That would be kind of a good idea to know that. And then we talk about minute volume, and minute volume is that tidal volume times their respiratory rate. So I said before that tidal volume typically is somewhere around 5, 6, 700 cc's or milliliters. By the way, cc's or cubic centimeters and mLs, milliliters, is the same. One is a unit of measurement for liquids typically, and one of them is a unit of measurement for length. Well, a cubic centimeter and a milliliter are the same. They're equivalents. So if we say 500 milliliters and the person's breathing 10 times a minute, we can multiply those together. 500 times 10 gives us 5,000. Or in the example that they show on 199 of the asthma patient, their normal tidal volume of 500 mLs. They're having an asthma attack today, so he's only moving 300 mLs per tidal volume. And the air in the dead space remains constant, so we're going to leave that alone. But so we're going to say his normal tidal volume is 5,000 times 16 breaths a minute, or 8,000 mLs. But in his asthma attack, tidal volume is 300 mLs times 16 breaths per minute equals 4,800 mLs, so almost half. So it's a significant change there when you change the tidal volume. The thing about dead space is dead space doesn't really change. So you don't change the length of your trachea or your bronchioles. So you're still out 150 mLs, which is rough guesstimate of what most people will have for a dead space is roughly 150 mLs. So you really, and when you take out that dead space, you really have a major change there in their tidal volume, or their minute volume, sorry. So normal minute volume, the next example down, let's say we have a person that's overdosed on morphine or codeine. Those types of drugs tend to slow your respiratory rate. So if we would have a person with a normal minute volume of 500 times 16 equals 8,000 mLs, or 8 liters is the same, but we get high on a narcotic, an opioid narcotic, we slow our minute volume down, our respiratory rate down to half of that, or 8 breaths per minute, with still a tidal volume of 500. We cut that easily in half. So if we need 6 or 7 liters, or 6,000, 7,000, 8,000 milliliters to survive. That's what our norm is. And we cut it down so much, the body really starts to go into basically a shock state. So, all right. Moving forward, respiration. So, evaluating respiration. The brain, the body, cells need a steady supply of oxygen. We have a couple of terms that we use with this. Hypoxia. Hypoxia is a low oxygen level in the cells. You may also hear the term hypoxemia. That is actually low oxygenation of the red blood cells. Okay, so hypoxia is in general, hypoxemia is very specific to the blood. Carbon dioxide must continuously be removed, and if it is not, we get hypercapnia, which is a high carbon dioxide level. I want you to take a moment and, if I haven't mentioned this before, understand there is a difference between carbon dioxide and carbon monoxide. Carbon dioxide is CO2. Carbon monoxide is CO. Carbon dioxide is a normal byproduct of animal life, and it is a primary element for plant life. And vice versa, oxygen is a normal product of, or byproduct of plant life, and the normal building block or major component for life of animal life. So CO2 is relatively safe, although over a period of time of it building up, it becomes a problem. CO, carbon monoxide, which is a normal byproduct of burning stuff, particularly fossil fuels, is not safe for animal life, and there are I can't think of any animals offhand that deal well with carbon monoxide. So carbon monoxide is toxic. Carbon dioxide over long periods of time is bad for you and in higher levels, but carbon monoxide should not be confused with carbon dioxide. All right. Assess how well the cardiopulmonary system is accomplishing the oxygenation and carbon dioxide removal. So we have to look at our patients. This is a lot of times when we're talking to patients, we're trying to get their mental status. We're looking at their skin. We're looking at how well they're breathing. We're talking about, are they sweating? Are they pale? Are they cyanotic? Cyanotic is a new term we haven't come across yet. Cyan is blue, so cyanotic is a case in which a patient has a blue tone to the skin. And so cyanosis would be a sign that the patient is not oxygenating well. So there's a number of things. We're going to touch on those here when we determine how well is respiration occurring. Respiratory compensation. The concept of respiratory compensation is when a person is working to overcome something that's gotten out of balance within their body. So we may be talking about a patient who starts to hyperventilate a little bit. We have a type of patient we deal with from time to time. It's a patient with diabetic ketoacidosis, and diabetic ketoacidosis builds up a lot of extra acids in the body. The body's attempt to fix that is to increase the respiratory rate and usually the respiratory volume that goes along with that. And in those cases, we'll see very heavy, fast respirations. It's something called Kussmaul's respiration. But that is a common respiratory compensation mechanism there. It also may say, well, instead of having hypercapnia, which we see in the diabetic ketoacidosis, maybe it's a hypoxia case in which the patient hasn't been breathing very well at all, and now all of a sudden they're hypoxic and their respiratory rate will start to pick up. Signs will be some shortness of breath, which is technically a symptom we would see respiratory distress as a sign. Now, a couple more terms here, signs and symptoms. Signs and symptoms, when we're talking about patients, signs are things that we can see as a healthcare professional. So, patient has cyanotic skin. We can see that. That's a sign. Symptom is something that the patient has to tell us, such as, I feel nauseated. Well, if they feel nauseated, we can't see nausea. They have to tell us that. Or if they're telling us they're having a difficult time breathing, we can't see difficulty breathing. We can see them working harder to breathe, but we don't know that in fact the patient is having a difficult time breathing. It may just appear so. Increased respiratory rate, depth, increased heart rate. These are all signs that the respiratory system is just trying to pick it up and trying to keep things on an even keel. Early on, steps for compensation can meet the body's need despite the respiratory challenges. So a little bit of a quick pickup. Maybe we have a normal respiratory rate of 12 per minute and our body kicks it up to 16 a minute. That can potentially tide us over for a little while. But if the problem goes unsolved, the problem is not fixed, that's when we end up having an issue with compensation eventually not being able to cut it anymore. So respiratory distress. Respiratory distress is the body compensating for respiratory challenge and to try to meet that metabolic need. So the body now needs more oxygen, and that's going to increase the patient's respiratory distress. They may have labored respirations, which means they work harder to breathe. There are some other signs of inadequate breathing that we'll discuss. Here we go. The signs of respiratory distress. They have a relatively normal mental status, although they probably will be fairly anxious. They will have a relatively normal mental status in most cases. If they had, and when we say normal, I don't tend to like the term normal because it's very subjective. Their mental status is fairly normal for them. It may not be normal for us, but if this is that patient's normal status. A relatively normal oxygen saturation and end-tidal carbon dioxide level. We're not usually able to check that at the EMT level, but the end-tidal CO2 is telling us how much how much carbon dioxide are they exhaling, and is at a relatively normal level. The oxygen saturation, though, is something that we can check on a regular basis by using a little finger probe and a pulse oximeter, and that will give us a fairly good idea of where they're at. Pulse oximetry, we'd like to see above 94%. So if they're still in the 90s somewhere, that's relatively normal. We're okay with that. Relatively normal skin color. They may be a little bit on the pale side, but in most cases they look pretty normal. Maybe just a very slight variation, as opposed to when we see people that are worse off. We can see them sometimes with a grayish skin color. They're complaining to us of shortness of breath. They're having a hard time catching their breath. They have an increased respiratory rate and usually an increased heart rate. And then the accessory muscles may be used and they may change their position. So if we back up one slide here, this little girl is propping herself up, something we call the tripod position. She's propping herself up to try to maximize the use of her muscles to get a good breath of air in. This can progress on to respiratory failure. And respiratory failure occurs when the challenge overcomes the compensation, or the compensatory steps no longer continue. A lot of times we'll refer to this as inadequate breathing. And it's exceptionally important to recognize this. It's often a precursor to respiratory arrest. So signs or symptoms of respiratory failure, they'll have all the same signs of respiratory distress. However, many of them may have progressed. Evidence of compensation is no longer effective. The signs of poor oxygenation and poor CO2 removal, and they have signs of decompensation. So the respiratory rate is getting worse, or getting much higher. They're struggling much harder. The oxygen saturations are dropping. The skin color is worse. Their heart rate is perhaps even coming down. They'll have these altered mental status, so they may no longer be able to stay fully alert to what's going on. They may be kind of dozing or zoning out. The cyanosis, as I mentioned. The signs of decompensation include no to poor air movement. So when we listen to their breath sounds, maybe we heard something that didn't sound so good earlier, we may not hear anything now. Breathing rate is too rapid or too slow. It's very irregular. Normally they're very timed out. Every 2.5, 3, 4, 5 seconds, almost like clockwork, you can clock this out. But if it's up, down, up, down, up, down, up, go, fast, go, 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 that would be irregular. Patient is unable to speak or is only able to speak in just a couple of words, 1 or 2 word little phrases. They'll have some unusual noises such as wheezing, which is kind of a musical sound. Most people have probably heard wheezing, maybe even from yourself. I know, like, if I had to go out and try to well, run anywhere right now, I would be wheezing. Crowing, or kind of a very loud squeak. Stridors, snoring, gurgling, and gasping. Pediatric side, we talked about retractions and nasal flaring in Chapter 8, and again that kind of rears its head here in Chapter 9 as well as a sign. And then the critical decisions. When do we intervene? Often respiratory failure patients will be breathing unconscious. We have to identify how adequate is their breathing, and do we have to do something for them. If their mental status is getting way off, their respiratory rate is way off, we need to intervene. And we sometimes will have to ventilate a patient that's still alert, and that can be a very difficult thing to do. It's hard to get somebody to let you breathe for them while they're still doing it on their own. But it's critical that we do something, and we try to time it to go with them. So when they take a breath, we give them a breath. We may try to squeeze one in between, and then the next time they take a breath, we try to give them a breath. We try to squeeze one in between, or we may just try to slow them down. We may start bagging them very fast with their respirations, and then slow it down. Start to slow it down, giving them better breaths, letting them get some air out before another breath of air comes in. So what signs might identify the need to intervene in a breathing patient? They're unconscious and can't control their own airway, obviously would be one. Patient is basically not aware of their surroundings. Their respiratory rate is very, very high or very, very low. So we kind of touched on these. So before we move on to positive pressure ventilation, just to take another second to review those 3 major categories of cardiopulmonary failure. Mechanics are disrupted, so the chest wall is damaged or injured. The nerves aren't controlling it anymore. There's a major injury that has taken part of the chest wall out, or they have an airway problem and they can't move air in and out. That are mechanical issues. Gas exchange issues, whether we have low oxygen in the environment or we can't get the oxygen across the membranes where we need to. And then circulation issues, they don't have enough blood or the blood is not adequate to move it around. And those are out of your book off of page 200, but very, very important, because we're going to come back to these time and time again and say, really, what is the gist of this problem? So now there's another term that we're going to throw at you here, and that is respiratory arrest. Respiratory arrest is complete stoppage of the breathing. The other term for this is apnea, when the patient is apneic. So there's a chart in your textbook on 203 that kind of helps us compare adequate versus inadequate versus respiratory arrest or apnea. It gives us some signs to go along with it and things that we can do for this person. Usually adequate breathing means we give them a little bit of oxygen. Inadequate breathing, we may be assisting them with some breathing. And then respiratory arrest, we're doing the breathing for them completely. All right, so positive pressure ventilation. What does this have to do with what we're doing? Positive pressure ventilation is our attempts to move air into the patient. We've kind of skipped ahead a few pages here because this is a lot of the stuff that we've kind of covered along through the PowerPoint here, but there's very good charts, some very good bullet points on there that cover the concepts of adequate versus inadequate breathing and some hypoxia and so on and so forth. So we move to positive pressure ventilation, which is what we're going to do for the patient that's not breathing adequately or at all. And we're forcing air, which is hopefully oxygen-rich, into the lungs when a patient has stopped breathing or has inadequate breathing. And we're going to use that force exactly opposite of how the body normally draws air into the lungs. So this is different. And you may not think it's a big deal, but people who are typically on a ventilator will know just how big of a deal this is by changing just little bits and pieces here. It can really, really screw things up for these people. So positive pressure ventilation can be very sticky, can be very difficult for us to do adequately for our patients. So there are some negative side effects. Decreasing cardiac output and dropping of blood pressure. When we stack too much air in their chest, their heart can't pump efficiently. So that's why we have to pay close attention when we ventilate. We can get gastric distension, which means we maybe breathe a little too fast, we push a little too hard, and air goes down in their gut. And when that air goes down in their gut, then they the gut starts to expand and makes it difficult to ventilate them. And eventually that air has to come out. It's only 2 feet to come back out the way it came in, or some odd 40 feet to go the other way. Which way you suppose it's going to come, and it's going to bring friends. So hyperventilation, sometimes we hyperventilate patients. When we hyperventilate patients, we can cause their blood vessels to shrink, particularly in their brain, and it will actually have a bad side effect of actually reducing the amount of oxygen available to their brain. So some key concerns here. Do not ventilate a patient who is currently vomiting or has vomitus in the airway. If you do, you force the vomit back into their lungs. Suction them out or use your fingers to sweep some of that out and then suction the rest. Watch for chest rise and fall with each ventilation. So, and ensure the ventilation rate is sufficient. So when we are ventilating patients, we need to think about what is their norm. And in most cases, that norm is somewhere around 10 to 12 breaths per minute. For giving them a good quality of ventilation, that should be sufficient to most people. It's very easy to get a little overexcited about this and be bagging away at 40 or 50 times a minute. That does no one any good. It exhausts you, and it causes a lot of potential side effects for the patient. So watching for chest rise and fall with each ventilation, that's a good way to say, yes, this is working for this patient. I can see what I'm doing is actually being effective. And then remember, keep that rate at a normal respiratory rate. If you have to ventilate a breathing patient, explain the procedure to the patient. They are not going to immediately like this, but they will eventually figure it out, and usually it's within a couple of breaths that, hey, this is okay, they're helping me. So you seal that mask on the patient's face, and you squeeze the bag with the patient's inhalation. So as you see them start to inhale, then you give that the bag a squeeze, and you assist it along in there with them. And this might be weird, again, might be weird for them for a little while until they kind of get the picture of how this all works. So mouth-to-mask ventilation, this is usually done if we're kind of like basically first responding. We're the first one there, we don't have all the equipment, the ambulance maybe hasn't gotten there yet, we may use a pocket face mask. In this case, this is a very common one that we see in the industry. It's got a one-way valve there, it's got a filter in there, there's even an oxygen inlet port below the filter there. You can hook up an oxygen tube to that and increase the oxygen. The sharp end of this, the top of the teardrop, goes over the bridge of the nose, and the more blunted part around the bottom side obviously goes around the chin. If you need to use it on an infant or a small child, you actually can flip it upside down and possibly get it to work. Yes, you're going to probably cover their eyes with part of this, but if you need to breathe for this infant, it's something. So the use of a pocket mask. First of all, open the airway. If you have the ability to hook it up to oxygen, great. If you don't, there is a way you can actually increase the amount of oxygen you pass on to your patient. If you would put yourself, if you have access to oxygen but don't have an oxygen port in your mask, put yourself on a nasal cannula and crank your nasal cannula up to about 6 liters per minute. You will give yourself more oxygen, therefore whatever you exhale into the patient will have more oxygen in it. Your body is not going to use more, your body will still use the same, but if you had more to begin with, then you have more to pass on. You can position the mask over the patient's face, put that apex or the sharp side of it over the bridge of the nose, and then the base between the lower lip and the prominence of the chin. You should position your hand around that mask. Now, depending in the case of doing a mouth-to-mask, usually you can do something kind of like represented in the picture here, where you hold the jaw with your fingers and you use your thumbs to put pressure on the sides of the mask basically equally. If you would have to do it one-handedly, you would wrap one hand around the stem of the mask, and then kind of do what's called the EC clamp technique. So your pointer finger would move up from the patient's jaw to the bottom side of the mask, while your other hand kind of wrapped around the top side of the stem. So you put your mouth over the exhalation port of the mask and breathe into the mask. You would want to not breathe terribly forcefully or quickly, but breathe until you start to see the chest rise. Once you start to see the chest rise and you're looking right at it, then you can then, if you want to remove your mouth from that, definitely stop blowing, but you can take your mouth off and get another breath of air, and then that patient will passively exhale through an exhalation port. Really, the exhalation port on that mask, if you, on the bottom side of where his lips are on the stem there, the bottom side that kind of hangs over like a little cliff, that is actually the exhalation port. You can see the rubber valve in there. It's yellow. That yellow rubber valve will kick, as the patient exhales, will kick up and blow out the bottom side. So to achieve a nice mask seal, position the thumbs over the top of the mask, index fingers over the bottom of the mask, and then the remaining fingers under the patient's jaw. Or you can position your thumbs along the sides of the mask and the remaining fingers under the patient's jaw. So there's a couple of ways you can kind of maneuver. And it's going to depend on your own anatomy as well. If you have larger hands or smaller hands, typically we have dainty females might have a difficult time getting mask seals, so they have to work a little harder to find a technique that works great for them. The bag valve mask. The bag valve mask is a handheld ventilation device. It's used to ventilate non-breathing patients and or the patients in respiratory failure. This is probably the most commonly used method of ventilating a patient in EMS. There's a couple of ways to do this. There's one person or two person, and two-person bag valve ventilation is typically much more efficient. You don't have to struggle as much for a good mask seal, and you can squeeze the bag well. Different schools of thought on which is better, mouth to mask or bag valve mask, or another device that we're going to talk about is the oxygen restricted ventilatory device, often called the demand valve. But some of the schools say that mouth to mask is better because you can get better volume, while people will say bag valve mask is better because you can give them a higher concentration of oxygen. Kind of the mask things, the mouth to mask things, kind of gotten out of favor because we don't have to give them huge volumes. What we do need to do is give them an appropriate volume to see the chest rise, and so having to blow 4 or 5 liters of air into a person is not as big of a deal. The adult bag valve mask that you see in the picture, if you could deflate it completely, you would give them about 1,600 mLs of air, or just over 1.5 liters. So still, there still remains debate on which is the best method to use. If you're alone, you're probably best off to use the pocket mask. It's just going to make things easier for you. If you have extra hands around, by all means, bag valve mask is probably the way to go. So standard features for our bag valve mask. If you want to look at the picture of the bag valve mask that we just had, you can look on page 212. It's a self-refilling shell that's easily cleaned and sterilized. Well, I don't know about that. Most of these are disposable these days. We don't have to worry about cleaning and sterilizing, but self-refilling is for sure. So it needs to be kind of a basically rubberized, almost cylinder-shaped, egg-shaped device that basically pops back up. There's a different type of bag called an anesthesia bag, in which it isn't necessarily self-refilling. It slowly refills with oxygen or gas, whatever gases they're pumping into the patient, and then they can just give it a nice light squeeze and it breathes for the patient, as opposed to these that we need to kind of pop back quickly in case we don't have a good gas source. It needs to have a non-jamming valve that allows oxygen inlet flow of 15 liters per minute. Should also have a non-rebreathing valve, so when the patient blows out, they exhale, it exits out of the bag, doesn't get back inside for the next breath. So it's always whatever came out of the reservoir. The reservoir is the plastic bag. The non-rebreathing valves you can see in there, they're basically orange. You can look real closely, the orange, little orange parts inside the clear plastic. That's where that will exhale the air. And here's that picture again. So you can see where the non-rebreathing valve is, face mask, we have oxygen supply tubing and a reservoir, the intake valves, and the ventilatory bag itself. So it's kind of standard. You can use a big, an adult-sized bag valve mask on kids, but it's not always very easy to use a kid-sized bag valve mask on an adult. So if you're in a pinch and you can only grab one bag, the adult would be the way to go. And you remember, you're going to squeeze the bag until you see the chest start to rise. Once the chest starts to rise, you let go. You stop blowing in, you let them exhale. So the mechanics of our bag valve mask, it supplies us with 15 liters per minute of oxygen, and it's attached and enters the reservoir. We can crank it up above that. We can actually use it without any oxygen if we had to, if we ran out of oxygen. So when we squeeze it, the air inlet valve closes. The oxygen is pushed out then into the patient. And when we release it, passive expiration by the patient, then we'll close the delivery valve and open the exhalation valve and blow that air out the side. 2 rescuer BVM. This is the probably most recommended by the American Heart Association. It really reduces your chances of any contamination of the patient. The most difficult part of bag valve ventilation is getting a good mask seal, and this is something we've struggled with for a while. That's why when we talk about King Airway, if we can go to King Airway and use the King Airway, we don't have to struggle with mask seal. The mask seal situation is gone. So one rescuer can squeeze the bag, the other rescuer can maintain the seal. So you can wrap both hands around and hold that mask on there nice. So open the airway with head tilt chin lift maneuver. Select the correct bag mask, valve mask size, of course. Kneel over the patient's head and position your thumbs over the top half of the mask, index fingers over the bottom half. Kind of like he's showing there, except use both hands. The apex of the triangular mask over the bridge of the nose, and the lower part over the mouth and the upper chin. Use your middle and ring and little fingers to bring the patient's jaw up with the mask. So you're kind of doing a jaw thrust, basically. However, you can still do the head tilt chin lift maneuver with your fingers. They can continue to pull the chin upward. So, the second rescuer connects and squeezes the bag, and then they also release the bag, and the patient will exhale passively. Remember, we're squeezing until we see the chest start to rise. If we have a suspected trauma patient, we basically have to modify our approach to holding the patient's airway open. We opened it initially with a jaw thrust. Still select the right bag size, kneel next to the patient's head, place the thumb sides of your hands along the mask to hold it firmly in place, and use your remaining fingers like they show here to bring the jaw upward without tilting the head or neck. Other than that, everything remains the same. One rescuer bag valve ventilation. You're going to open the airway, select the correct size mask, position it on the patient's face. You're going to wrap what we call the EC clamp technique. So basically, you do the A-OK sign with your hand. So your your pointer finger and your thumb, your forefinger and your thumb in an O around the mask stem, and then the other fingers pulling backwards to open the jaw up. Again, squeezing the bag till you see the chest start to rise, then let it go and let the patient exhale. So what can we do if the chest does not rise during ventilation? Reposition the airway. You can check for escape of the air around the mask and reposition fingers and so on and so forth. Check for any airway obstruction, or make sure that the bag valve mask system is able to work correctly. Or use an alternative method. Preferably, if you can't use the bag valve, then probably the pocket mask is the preferred. Oddball situations, say, we may run into artificial ventilation of a stoma breather. So if we have a stoma breather, this is a person with a hole in their neck, and it's usually down right above the collarbone area. Leave the head and neck in a neutral position. You may need to do a little bit of suctioning with your French suction catheter right there. You can use a pediatric-sized mask to establish a seal around their stoma, and then ventilate at the appropriate rate. So you're still going to use an adult bag valve mask just with a PD mask. And then if you're unable to artificially ventilate through the stoma, then you can attempt to seal the stoma, usually with, say, a gloved finger over the top of it, not in it, over it, and then attempt to artificially ventilate them through their mouth and nose. Usually that they're still fully connected, and you can move air through either method. The flow restricted oxygen-powered ventilation device. This is also commonly called the demand valve. This is basically a high-pressure ventilator system, in which you pull that trigger, silver trigger thing, and it's going to keep blowing air in them as long as you keep that depressed. So the demand valve really kind of has fallen out of favor. It's only used on adults. Same basic principles and procedures as the mask seal for the BVM. And then you have to watch very closely. Once that chest starts to rise, you got to let go of the trigger. You got to either take your finger off the button or let go of the trigger. Otherwise, you're going to blow way too much air into your patient. These have been known to give patients collapsed lungs. Automatic transport ventilator. This provides some automated ventilations for your patient. You can usually adjust just a couple of little things such as the ventilatory rate and the volume. So you would kind of come up with whatever the general tidal volume should be. And if you remember back to the beginning of the chapter, we said somewhere in the 5 to 7 cc's per kilogram range is what we're looking for. And you would determine what your volume would be, your tidal volume, and then your ventilatory rate, which we know is typically somewhere in about the 10, 12, 14 per minute category. We can sometimes select how much oxygen we're going to do this with, but that's usually about the extent of what you get out of an automatic transport ventilator. The provider must assure appropriate respiratory rates and volumes for the patient's size and condition. So you're going to have to monitor this patient very closely. So how would you decide which positive pressure delivery method to use for your patient? You have to look at all of the circumstances surrounding. Am I alone? Do I have help? What sort of equipment do I have at my disposal? Do we have a mass casualty situation in which we're going to be stretched very thin? Do I have any oxygen? If I don't have any oxygen, then I can't use the demand valve. So there's a lot of potential questions that have to be answered before we move forward in selecting that. But in most cases, bag valve mask, two-person bag valve mask, would be our preferred method, as opposed to one person or the other devices. Okay, oxygen concentration or oxygen therapy. Oxygen therapy obviously is a common skill that we perform in EMS. A significant number of our patients will receive supplemental oxygen, and there's a couple of different devices that we will use in oxygen therapy, as well as a couple of different systems that we will employ to actually deliver the O2 to the patient. So conditions requiring supplemental oxygen are respiratory or cardiac arrest, heart attacks and strokes, shock, respiratory disease, lung diseases, head injuries, altered mental status, other serious injuries. So there's a lot of times in which we're going to give supplemental O2. The two major systems that we use to give this oxygen are the portable, or the they refer to it as install. We usually refer to it as a house tank or the main tank. The picture doesn't really do it justice, but the bottles that you see on the left are your portable bottles, and what you have is a D and a jumbo D and an E. It's the jumbo D, then the D is in the middle, and the E is on the right side. Those are typical portable bottles. Most places are using one of the two D cylinders. It just fits nicer. The D cylinder stands just about 2.5 feet tall, where the E cylinder is probably just a little more than 3 to just a little bit more tall. The house tank, though, the main tank that you see, is a good 4.5 foot tall, and it's significantly larger around than is the portable bottles. So you've got way more oxygen in the house tank. Now what you have to keep in mind is the pressure that the tank shows isn't a direct correlation to the amount of oxygen that's left. You have to understand that a full tank of oxygen, regardless of the size, is around 2,000 pounds per square inch, or 2,000 psi, which doesn't necessarily mean the same. If you look at page 219 in your text, and then 220, you will see that a D cylinder contains about 350 liters of oxygen, whereas an E cylinder has about 625, and an M cylinder, which is probably what that house tank is that they're showing, that M cylinder has around 3,000 liters of oxygen in it total. There are some other cylinders that you may use from time to time. The G or the H, obviously those hold way more oxygen in them. If you needed to figure out the duration of how long it should last, you'll take the pounds per square inch minus the safe residual pressure, which is a minimum of 200 psi, times the constant, which they show you the constant on page 221 for the various size cylinders, and then divide it by the flow rate in liters per minute, and that'll give you your duration in minutes. This is something you're not usually going to have to do. But let's say you work for a company that was doing a long transport. For example, the company that I work part-time for recently sent a crew from Omaha to southern Arkansas, and they had a patient on oxygen. We had to figure out how much oxygen are we going to need to send along. So using a formula like this would help us figure that out to determine, does what we normally carry on the ambulance enough, or do we need to send spares? Now, also on page 220 in your textbook, it shows you the oxygen bottle laying down. That is the safest position for that bottle to be in. If you have an oxygen bottle sitting up and it gets knocked over and the neck or the valve gets damaged, that pressurized bottle becomes a lethal rocket. That little bottle, that little D tank, you break the neck off of it, it will shoot through a cinder block wall. So it is dangerous. The good thing about oxygen is that oxygen alone is not flammable, but oxygen enhances burning. So we can take and have an open flame in the presence of oxygen, and it's not going to explode. But if there's a fuel source, such as an oily nasal cannula on a patient's face, now you have the heat and the fuel and the oxygen, and the sucker is going to burn. So it's not flammable, but it enhances burning. Additionally, oxygen bottles are usually green in color or have a green cap over an aluminum cylinder. You can see an aluminum cylinder is the one on page 220. It's spun aluminum, usually has the shoulders, and leading up to the neck is green. The rest of it's silver. While the house tank that they show on 221 is a cast iron or cast steel tank. It is a very heavy tank compared to the aluminum tanks. So oxygen system components. Here we have an orange case that some places may use in order to protect their oxygen bottle. Obviously, they understand the potential dangers with the pressure. There's the oxygen bottle itself. The main pressure regulator that goes on there. That's referred to usually as a regulator. The ones in ambulances are usually called flow meters. Now the pressure regulator, is what takes the pressure down to a usable level. There's the flow select valve, which they have listed here as the flow meter, but the flow select valve is you're gonna dial up whatever amount of oxygen you want to give in liters per minute. We can do this as little as, depending on your regulator, as little as a quarter liter per minute, and usually they'll max out at around 25 liters per minute. You have the toggle on the top of the bottle, which isn't marked, but that toggle is how you open the bottle up and allow the oxygen out. There is a kind of a T-bar across on the back side. It's marked as the main valve, and that valve, that is actually a thumb screw to help secure the regulator to the bottle. And then you have obviously a dial there. They have marked as the pressure regulator. It's really not a regulator. It just tells us that it is how much oxygen PSI, pounds per square inch, is remaining in the bottle. I said a full bottle is roughly 2,000. Sometimes we get them with just a hair more, just a hair less. We consider, most places consider an oxygen bottle empty at 500 psi. You don't want to run with anything less than 500 psi. 500 psi will get you by on a nasal cannula for a little while, but it won't get you very far if you put them on a non-rebreather or on a bag valve mask. And there's a barb up there that you attach your tubing to, and that tubing leads to your oxygen delivery device, in this case a non-rebreather mask. Here's oxygen cylinders like we talked about. Different sizes, about how much oxygen they have in there. Oxygen is abbreviated O sub 2. It's not O to the second power, it's O with sub 2. To get a new bottle, they typically will have a seal around the neck like you see the white tape here, and in most cases there will also be a washer or a gasket in there that will help it interface with the regulator itself. And some places will also have these tags on it marking this is a full, partially full, or an empty tank, so you know not to put an empty tank back in the truck. So oxygen safety: use pressure gauges or regulators and tubing intended for oxygen. On portable bottles, you can only use an oxygen regulator on an oxygen bottle. There's a specific setup that won't allow you to use other ones. We'll touch on that in a second. Use non-sparking wrenches. Usually we have plastic wrenches that we use if we have to use an O2 wrench. Replace the disposable gasket each time the cylinder is changed. They will wear over time. Properly secure the cylinder in a cool vented space, and so it's not rolling around. And then never drop a cylinder or move it by dragging. You'll weaken the cylinder. And never leave it upright without being secured. Technically should be secured in some very specific manners. Never allow smoking around oxygen or use oxygen around an open flame. Never grease or use adhesive tape on the cylinder. And then test your cylinders hydrostatically every 5 years. Cylinders need to be sent away, or tanks need to be sent away, and they'll be run through a testing process where they are submerged in water, and they'll add X amount of pressure to it and watch to make sure that the tank is holding pressure and is structurally sound. So the pressure regulator, like I mentioned, we have a pressure regulator on the oxygen, the portable bottle here. You can see where it says in the picture on the left, it says off in the little circle. on the end, right where his hand is at, there's a little black dial on the inside of there that you would then turn that and you would move it from off to whatever liter flow you wanted. There's a little oxygen fitting or barb hanging off down below under right by his fingers. And then he's putting the thumb screw down and securing the regulator on there. The other one, they're showing an example of a house tank, and that has a specific type of fitting that should only allow oxygen regulators to fit on there. However, it's not as specialized as the system with the pressure regulator on the portable bottle. If you would look at, I'm find the picture of where it was. There's a picture on 226 in your textbook, and on there you see that the oxygen bottle in the picture number 5 there's 3 holes in the neck of that. The bigger hole is where the oxygen actually flows through. The 2 lower holes are what's called a pin system, and those pins are pin number 2 and pin number 5. Out of a total of 6 potential spots to place those. Pins 2 and 5 correspond to oxygen. If you look at the regulator, you can see it even better in picture number 7 there. There are 2 pins on the inside of that the regulator where it's going to fit down over the neck of the bottle. And so those 2 pins will slide into those 2 holes and only allow you to put that oxygen regulator on an oxygen bottle. So carbon dioxide is a different pin number setup, as does medical air, as does nitrous oxide, and all the various gases have specific numbers and how they set their pins up. So you can only use certain types of regulators with certain types of gases. And here's the picture that I was exactly talking about. The 2 and 5 pin system, they're putting a gasket over the oxygen inlet for the regulator, and then you'll slide that down over the top of the bottleneck and secure it with the thumb screw. So our oxygen delivery devices. Non-rebreather, a non-rebreather mask is the best way to deliver high concentrations of O2 to our breathing patients. An example of a non-rebreather mask in the picture. Obviously there's the oxygen inlet tubing. It connects into the neck there, and it will fill up that bag. In order to get it started, when you go to use a non-rebreather, you take it out of the package, you unfold it, hook it up to your oxygen source, turn on the oxygen source, and then stick your thumb in there inside the mask and put your thumb over that valve. You can see the little flapper valve that's just above the oxygen tubing. You put your thumb over that and it will fill the bag for the first time. After that, it generally will fill pretty easily on its own. You can let it fill on its own. It will do it. It just generally isn't quite as quick. On the sides of the mask, you can see it on the right side of the mask. You can't see the one on the left, but there's one there as well. Are 2 more flapper valves, and those flapper valves are the exhalation valves. So the way this works, the oxygen fills the reservoir bag. The patient takes a breath that opens the flapper valve on the top of the bag there and allows them to draw air or draw oxygen out of that bag. Then they exhale. When they exhale, it closes that flapper valve on the top of the reservoir bag and opens the flapper valves on the side of the mask to exhale. And that's how that mask works. You obviously have a strap to go around their head, and then there you can see the metal band kind of across the bridge of that. And that aluminum little band there is used to help adjust it across the bridge of the nose, so it gives a fairly decent contact with the patient's face. It's not a perfect seal. With this, they actually are calling this a non-rebreather mask, and that's incorrect. This is actually a partial rebreather mask that they're showing in the picture. A partial rebreather mask doesn't have the flapper valves on the side. So if you have a non-rebreather and you want to make it a partial rebreather, you just pull the flapper valves off. They're just little rubber gaskets. And in this case, they don't have the rubber gaskets on the side, so it's a partial rebreather. And they can partially rebreathe some of their own oxygen. There's a good table on page 229 in your text that discusses some of these different devices, their typical flow rate, their oxygen concentration, or what we call an FiO2, which is fraction of inspired oxygen, their oxygen concentration they'll deliver, and then some general notes on it. The non-rebreather is typically run at about 12 to 15 liters per minute. You can go dip down about as far as 10 and still be pretty safe. And it'll give you 80 to 90% oxygen, even sometimes upwards to 95%, depending on how well you fit it to their face. And we'll take, for example, the picture here. If you look at the girl's chin, there's a lot of space underneath there, so there's going to be some outside air drawn in addition to the flapper valves being gone. She'll draw some in from under her chin. So obviously that's going to drop her potential oxygen concentration. So a non-rebreather, I like how they contradict themselves from the book to the slides, provides oxygen concentrations of 80 to 100%. Like I said, the better you fit it to their face, the better you will do. The minimum flow that you should never go below is 8 liters per minute. Otherwise, they're going to have a difficult time getting a good breath. And the maximum flow rate is typically 12 to 15. You can go higher if you have a flow meter that will allow you to do that, or a regulator that will allow you to do that. But here's the way to determine how much does this patient actually need. When they're breathing, pay attention to the bag. If the bag is sucking about halfway empty with each breath, that's about right. If it's any more than halfway empty, you should probably turn the flow up a little bit. If the bag is staying completely inflated the entire time, even when they're taking a breath, you need to A, reevaluate, are they actually breathing, and do we need to consider ventilating them instead of just oxygenating? Or 2, you can turn your oxygen flow down and conserve some. 15 liters a minute, you're going to run through a small D tank. If you started with a full one, you're going to run through that in all of about 20 minutes. So that's a way to conserve a little bit. Nasal cannula. This is a good choice for a patient who refuses to wear an oxygen mask, or somebody who's maybe their respiration or their saturations are a little on the low side, but don't need the full mask of the non-rebreather. They typically will give you around 24 to 44% oxygen, and you should deliver no more than 4 to 6 liters per minute. 6 is really the max. You can go as low as it'll go, as a quarter liter in most cases. We usually will say it's a 1 to 6 liter per minute device, and just as is marked in the book there. We use these actually quite a bit. It used to be EMTs were taught you just threw everybody on a non-rebreather, and we know that too much oxygen actually is a bad thing, so we've kind of strayed away from that. Partial rebreather. A partial rebreather is missing some of the valves, whether it's the one above the reservoir bag or ones off the side. It delivers roughly 40 to 60% oxygen at about 9 to 10 liters per minute. Rarely used in EMS. We're not going to even dwell on this anymore. Venturi mask. These are kind of a neat mask. Venturi delivers a specific concentration of oxygen by mixing oxygen with inhaled air. It has a very set percentage and flow rate and have adjustable Venturi ports. And the way that works, let's see if we got a picture. Yep. You can't see it very well, but down towards the woman's chest, you can see there's a kind of a cup, and there's an orange little valve in there. If you look, you can see it a little bit better on page 231, but those valves, different colored valves, you'll change out in there, or you'll change a little, you'll rotate a little valve on it itself, and it will tell you change the liter flow to 8 liters for 50% or 6 liters for 35%, and then you can deliver very precise flow for these people. These are very good for patients that have COPD, and we don't want them to have high levels of O2. And then there's a tracheostomy mask. And you can place this over the stoma or the tracheostomy. Usually we'll set it at about 8 to 10 liters per minute. It'll provide them some supplemental O2, and then depending on however the device is structured will tell us what percentage we can give them. Not a lot of places carry these though. And if they don't have a tracheostomy mask, you can always take a normal non-rebreather mask and just slide it down over their stoma or their trach. And there's an example of the tracheostomy mask. A humidifier. Humidifiers cannot be used with the portable system, but they can be used with the flow meter on the in-house truck or in-truck tank. And it provides a moisture source to the dry oxygen from the supply cylinder. People will complain that oxygen is very drying to their mucous membranes, so humidifying it is a way to avoid that. It's not terribly practical for us in EMS. One of the things is it's a one-time use and you ditch it. Another thing is we're generally not with the patient long enough that it's going to be terribly drying, and the patient is probably in a condition in which they really aren't going to have much effect from having this drying oxygen on their mucous membranes. We're going to get them to the hospital, and they can consider putting them on a humidifier in most cases. Rarely done in EMS. There's another oxygen delivery video you can take a look at. A couple of special considerations to think about. Facial injuries, bleeding and swelling can disrupt the airway, the movement of air, and aggressive suctioning and advanced airway maneuvers might be necessary. Just because we slap a patient on a non-rebreather doesn't mean all is good forever. They can quit breathing, their breathing can change significantly, they can vomit and not have very good mental status, and now this patient's got all this vomit trapped up against their face. So it's something that we constantly have to be looking at. That's why they're clear in color, so we can recognize those things pretty quickly. Obstructions. This is going to impede ventilation of patients. And if we're having issues with that, we are either going to have to do some finger sweeps or we're going to have to do some suctioning to try to get those out of there. Now, worst case scenario, they have a full form body airway obstruction. We may have to do some abdominal thrusts or some back blows depending on our patient. Pediatric notes, hypoxia can often occur very rapidly. Children burn oxygen at twice the rate of the adults. That's why they breathe a little faster. And there's a lot of different anatomical issues that potentially pop up. So it's important that we constantly are reevaluating, reassessing. Ventilating the pediatric patient, we've talked about this before. Pad underneath the shoulders to put the airway in alignment. Avoid excessive pressures and volumes. High pressures will blow lungs out. It happens all the time on kids. Use a properly sized face mask. Don't try to use an adult if you've got a kid one available. Do not use the demand valve on them. And gastric distension is easy. It occurs very quickly in kids. Just a couple of quick slides on assisting with advanced airway devices. If you are working with an advanced provider, and in this case we could consider the King airway as an advanced device, but for the purpose that we're talking about here, we're really looking at other devices. Paramedics may do direct visualization or put something called a laryngoscope in a patient's mouth, look at their vocal cords and pass a tube directly between the cords. Or there are other devices that potentially may be used the King being one, combi tube, LMA, PTL. There's a variety of other ones that may get used. Assisting with intubation, if you have a paramedic that's going to do some intubation, some things you may be able to help with, help maximize oxygenation prior to the procedure, whether they need to be oxygenated or actually ventilated. Helping place the patient in a sniffing position, providing cricoid pressure, which is pushing down on the cricoid cartilage. It helps line things up, and it helps reduce the probability of vomiting. Helping to confirm and secure the tube once it's in place. Ventilating the intubated patient. Very little movement can displace an endotracheal tube. We have to be very careful that anytime we move a patient, we're constantly double, triple, quadruple checking to make sure that tube didn't slip out. It can happen, and it happens fairly frequently. So pay attention to resistance to ventilations and reported changes. Let the paramedic know, hey, something's not right. Something doesn't feel the same as it did. If a patient is defibrillated, it's preferable that we remove the bag from the tube. We take the bag off the tube just to reduce the amount of oxygen that's in the general vicinity, but also if we just let the tube hang, there's the possibility it will pull the tube. Assisting with a trauma intubation, you will probably be helping with providing manual inline stabilization, and you're just going to be holding that stabilization but allow for movement of the jaw. So it's probably going to be earmuffs again, and the paramedic will try to intubate around you to get a tube in without having to move the head in too much hyperextension. Blind insertion devices. These don't require the head to be placed in a sniffing position. It does make it easier. It doesn't require it, but the King, you've got a whole lecture on that as well as some materials. Combi tube and the LMA, they're not used as frequently anymore. The King really has kind of come in and taken a lot of their places. There's a video you can watch if you want to on the endotracheal intubation. And then finally, we're in the chapter review again. So you guys can read through the chapter review. I can't emphasize enough stopping to take the time to read the textbook, go through, make some notes, look at, there's a lot of good diagrams, a lot of good pictures that are in the text for these very, very important topics. Look at the videos that are found in this week's course folder and review those. They will help you a lot to understand some of these concepts that I've talked through or you've read through the step-by-step. But go through those carefully, spend the time. This is an extremely, extremely important chapter. We've got to have, you need to be on top of your game from here on out. If you don't have this down now, chances are the remainder of the course has some difficult. You'll have some difficulty getting through all those concepts. So, questions to consider: what are the signs of respiratory distress and respiratory failure for BVM ventilation? What are the recommended variations in techniques for 1 versus 2 rescuers? How does the way positive pressure ventilation move air differ from normal body movement? And then describe a patient problem that would benefit from administration of oxygen and explain how you would decide what oxygen delivery device should be used. Your critical thinking. On arrival at the emergency scene, you find an adult female patient who is semi-conscious. Her respiratory rate is 7 per minute. She appears pale and slightly blue around her lips. Is this patient in respiratory failure? And if so, what signs or symptoms indicate this? Does this patient require artificial ventilations? Yes, this patient is in respiratory failure. And yes, they do require artificial ventilation. We know she's in respiratory failure because we have an altered mental status, Her respiratory rate is outside the normal range of 12 to 20, which is normal for most adults. Her skin is not looking correct. I mean, it's more than just a slight change. When you have pale and slightly blue around the lips, that's a pretty ugly picture of what's going on. So yes, she definitely does need ventilated.